Okay, great. So good morning once again. I'd like to invite you all to our 40th Annual Scientific Conference virtual edition that is running from 13th to the 16th of October. And our theme this year is Pharmacy Delivering Pharmacy Healthcare, Responding to Emerging Healthcare Dynamics. So my name is Dr. Catherine Wambura, and I'll be the host for today. So before we start, I'd like us to just say a word of prayer, and then we can begin the program. So I'll go. Our dear Heavenly Father, we come before you this morning, thanking you for the gift of life and for the beautiful day that you've given to us. I pray that in all the deliberations that we make today and the presentations that will be shared, you will enable us to learn and share well, and may you give us a good day. For I pray this trusting and believing through Jesus Christ our Lord. Amen. So my name is Dr. Catherine Wambura. I'm a pharmacist currently working at Mbagathi Hospital in Nairobi County, where I'm the pharmacist in charge at the CCC Pharmacy. And I have a great interest in matters public health related, and I'm currently pursuing a fellowship in epidemiology. So I will be your host for the day, and I'd like to begin with a few ground rules for those who may be joining us for the first time today. So thank you all for participating in this session and joining in with us. So I'd like to encourage that participants remain muted during the entire course of the session. And if you need to ask any questions after the presentations, kindly put them in the Q&A tab that's at the bottom of your window, and the questions shall be addressed by the presenters on the Q&A tab. And for the PSK members, if you have already not done so, please subscribe on the PPP portal for the conference so that you can get your CPD points. CPD points will only be awarded to paid up members. And for KPA members, the attendance list shall be shared with your officials for awarding of the CPD points. Kindly note that the session is being recorded and will be made available on PSK's YouTube page. Thank you for that. So right now we are going to go into the next item of the day, which is a GSK sponsor address on the use of Panadol in pain management. And I'd therefore like to invite Mr. Samson Kikuvi to take us through this presentation. Mr. Kikuvi, over to you.
Hello, good morning, everyone. Thank you for this opportunity. So yes, my name is Samson Kikuvi from GSK. I'm the expert marketing manager.
It may not be fair that we start causing problem among them.
Okay, yeah. So I hope you can see my screen and that I'm audible enough so that I can proceed. Someone to confirm? Hello?
Yes, we can see your screen.
Oh, perfect.
You can proceed.
Yeah. Perfect. Please move to the next slide so that I can start off the presentation. Okay, thanks. So I'll take you through these slides in terms of Panadol Extra with Optizorb. So we all know that pain management can be simple, complex, and this, of course, is dependent on the cause of pain. And the treatment in terms of what you can recommend to the patient is based on the history of the pain, its intensity, the duration of the pain, as well as the aggravating conditions and the structures involved in the pain. Panadol Extra, which is a formulation that of course, you've recommended most of the times and also interacted in your various practices, is approved for relieving headache, joint pain, back pain. We also have dental pain and dysmenorrhea. So these are the approved conditions that are very effective of being relieved when a patient uses Panadol Extra with Optizorb. Yeah, let's move to the next slide. Yeah, so the Optizorb technology speeds up the disintegration of the tablet so that it can be able to work in as little as 10 minutes. And the ingredients in Panadol Extra provide up to 37% more powerful pain relief than standard paracetamol. So the ingredients include paracetamol and Optizorb, like I've mentioned. And this 37% more powerful pain relief is based on a study that was done by Lasker in 1984, where he was able to show that paracetamol and caffeine has 37% more potency for pain relief across 6 pain studies that were done. And this, it was basically a meta-analysis of 30 randomized controlled clinical trials that involved 10,000 patients who were administered analgesics or analgesics with caffeine for pain relief. And the relative potency was statistically significant in 21 of the 26 studies. The potency estimate was 1.37, and this suggests 37% greater relative potency. And this is, of course, the combination of the paracetamol and the caffeine. So the role of the caffeine itself is to really enhance, it acts as an adjuvant and enhances the pain relief of the paracetamol. And that's why I find that also the mode of action tends to be faster compared to standard paracetamol. Move to the next slide, please. Yeah, so in terms of the caffeine, like I've mentioned, it's an adjuvant to analgesics, and this is based on a study that was done by Alaska, where it proved that it enhances the paracetamol in terms of enhancing the analgesic effect of the paracetamol in the various pain states. So the various pain states, we've looked at them in terms of the headache, the joint pain, the back pain, the dysmenorrhea, and dental pain. And in terms of the mechanism of action of the caffeine itself is a blockage of peripheral procinative actions of adenosine, activation of the central noradrenergic pathways, and also CNS stimulation. So in short, what the caffeine does is that it leads to inhibition of the transmission of the pain signals, and also leads to a mood elevation and reduced pain cessation on the patient. So that is what it does on your patient. Please move on to the next slide. Yeah, so we've looked at the various pain states that Panadol Extra with Optizorb is able to relieve. And the other addition that I can say is that Panadol Extra with Optizorb also reduces the fever on the patient. Yeah, move on to the next slide, which touches on, yeah, so this speaks to the role of Panadol Extra that is, of course, tough on headache. And this was based on a study that was done by Pini to look at the tolerability and efficacy of a combination of paracetamol and caffeine in the treatment of headache. So as you can see from the graph on the right-hand side, we have the x-axis, which shows the time in hours, and then we have the y-axis that highlights the pain relief in terms of the total pain relief. And then you can see on the graph, we have a placebo that has the triangles, yeah, and then we have naproxen sodium, which is an NSAID, and then we have paracetamol caffeine combination. So what the conclusion from this study is that the study confirmed that there's significant superiority of paracetamol plus caffeine over placebo in relieving headache, and that there is no difference compared to a reference drug like naproxen in both the reduction in pain intensity and in pain relief. Yeah, move on to the next slide. It's also tough on postoperative dental pain, and can be an effective alternative to ibuprofen. So this is based on studies that were done by 3 guys. We have Rashwan, we have Mola, and we have Kiesh. And they were looking at the efficacy of acetaminophen plus caffeine compared to ibuprofen in the control of postoperative pain after periodontal surgery. And from the study, you can see that acetaminophen plus caffeine can be used effectively in controlling postoperative pain, especially in patients that have ulcers. So that's why the recommendation here is that it can be used as an effective alternative to ibuprofen, especially for those patients who are not able to tolerate ibuprofen because, like I mentioned, due to gastric ulcers and also the tendency in bleeding. Yeah, and then the graph here just highlights in terms of the y-axis. This is the mean scores in terms of the numerical, based on the numerical rating score, and then the x-axis highlights the time in hours, and then you can see the comparison between paracetamol and caffeine. Yeah, and maybe to just highlight in terms of just maybe the key takeout from this page, from this graph, is that at 1 and 2 hours, acetaminophen plus caffeine showed significantly lower mean pain state score than ibuprofen, but from 6 hours proceeding up to 8 hours, ibuprofen showed statistically significantly lower pain scores in comparison to to paracetamol and caffeine. Yeah, let's proceed to the next slide. Yeah, so this speaks to its effect in terms of effectively treating dysmenorrhea. Yeah, and then this was also based on a study done by someone called Ali. Yeah, and this was to check on the efficacy of paracetamol plus caffeine in the treatment of the key symptoms associated with primary dysmenorrhea. And from the graph, so the comparison here was between paracetamol plus caffeine versus plain paracetamol. So you can see that at 2 hours following the dosing, this is the dosing was 1 gram paracetamol plus and 130 milligram of caffeine. So basically 2 tablets. It shows that it led to significantly greater pain relief compared to 1 gram of plain paracetamol. So this just speaks to show that it's more effective when it comes to treating dysmenorrhea in comparison to standard paracetamol tablets. Yeah, we can move on to the next slide. Yeah, so in terms paracetamol and caffeine is well tolerated, and it has a low risk of drug-to-drug interactions. Yeah, and then we have 9 well-controlled studies that highlighted that Panadol Extra with Optizorb has no treatment-related serious adverse events. Yeah, so you can safely recommend it to a majority of your patients. And then the ingredients of Panadol Extra Optizorb are safe on the stomach, and also it's suitable for use for the elderly people. Yeah, let's move on to the next slide. So this speaks to in terms of what the Optizorb technology is. So the Optizorb technology comprises of alginic acid, calcium carbonate, and crospovidone. So the role of alginic acid is to draw fluid from the stomach into the tablet, and this causes the tablet to swell and break apart. Yeah, and then the calcium carbonate works closely together with the alginic acid to boost the disintegration of the tablet. And then the crospovidone acts as the super disintegrant due to its ability to dissolve well in water. And this leads to now your patient getting relief from the various pain states that we've seen in as little as 10 minutes. Yeah, let's move to the next slide. So this, the next 3 slides speaks to the guideline recommendations on COVID. So because this is a current ailment that that you're facing in the hospitals, and of course doctors are looking at what are the analgesics that they can recommend to ensure that the patients are able to control the symptoms. So the European Medicine Agency 2020 says that when starting treatment for fever or pain in a patient presenting with COVID, a healthcare professional should consider all the treatment options available, including paracetamol and NSAIDs. Yeah, and each medicine has its own benefits and risks, which are reflected in its product information, and which should be considered along with the EU national treatment guidelines, and most of which recommend paracetamol as a first-line treatment option for pain or fever. Yeah. Move on to the next slide to see the second guideline in terms of COVID. So we have the National Institute Health 2020, where the panel recommends that there be no difference in the use of antipyretic strategies, e.g. with acetaminophen or NSAIDs between patients with or without COVID. And then the other addition is that the World Health Organization have included oral paracetamol and ibuprofen in the essential package of palliative care in patients presenting with COVID-19. Yeah. So yeah, let's move on to the next slide. So this talks to the summary in terms of what we've looked at. So we've seen that Panadol Extra with Optizol provides up to 7% more powerful pain relief than standard paracetamol. Yeah, and then the combination of ingredients help to fight multiple pain states that include headache, joint pain, backache, dysmenorrhea, and also pain after dental procedures. We've seen that it's effective in the relief of postoperative dental pain, especially in patients that should not take ibuprofen. It's suitable for use by the elderly patients. And then patients must be advised against the excessive use of caffeine-containing beverages and encouraged to read the patient information leaflet. Yes. So in terms of the dosage of Panadol Extra, yeah, so we recommend 1 to 2 tablets every 4 to 6 hours, and the maximum daily dose is 8 tablets per day. So that translates to 400 milligrams of paracetamol and 500 milligram of caffeine. Yeah, so that's the end of my presentation. Back to you.
Thank you so much, Mr. Samson Kikuvi, for that enlightening presentation on Panadol. We all are consumers of Panadol at some point in time. We have it in our hospitals. It's the go-to drug when you have a headache or any other form of pain. But of interest to me was the Optizol technology, which has really caught my eye. And the fact that paracetamol has been included in the essential package for palliative care by WHO. So thank you once again for a very good presentation, and thank you for supporting us in this conference. Thank you. So I'd like to now introduce our next presenter for the day. It will be an abstract presentation by Dr. Brian Lee Wafula on understanding patient medication experience at Coast General Provincial Hospital in Mombasa. And just a reminder, for any questions that we may have, kindly direct them to the Q&A tab and the presenter will answer you there. Thank you. Brian, are you ready?
Yes, I'm ready.
Okay, take it up.
My name is Dr. Brian Wafula. I registered in pharmacy. I registered in November last year, and currently I'm doing community pharmacy. So this research, I did it in while I was in my internship in Mombasa, Coast General Hospital. The topic of the study is understanding patient medication experience at Coast General Provincial Hospital, Mombasa. Next slide. The problem statement. Pharmacists in medication therapy management have struggled blending evidence-based practice guidelines for medication use with patients' medication outcomes. This preliminary research aims to identify and disseminate strategies to help pharmacists in MTM practice. Next. The study objectives was the study was aimed to explore the medication-related burden and patients' lived experience with medicines that without regard to particular medication therapies or medical conditions. The specific objectives was to develop tools for use in preventing and resolving drug therapy problems and understanding medication experiences. Next. So the study design, the study was a cross-sectional study at Coast General Hospital. It was done by means of questionnaires which were used to generate data these questionnaires were administered to patients undergoing therapy for chronic illnesses. The study was, of course, done at Coast Provincial General Hospital, Mombasa County. Next. The data that was collected from the research was validated, coded, and processed via Microsoft Excel sheets. Next. So these were the results of the study that I did. According to, as you see in the table, majority of the study participants were female at 56.7% and males at 43.3%. Most of these patients were aged between 46 and 65 years. Next. So this is the graph representing the average chronic medication indication. From the participants, we had females presenting with both diabetes and hypertension at 20%, as seen in the graph. Females presenting with only hypertension at 16.6%. Females presenting with only diabetes at 6.7%, and 16.67% with the HIV. Males presenting with only diabetes were at 10%. Males presenting with both diabetes and hypertension, also 10%. Males presenting with hypertension and heart failure, 6.6%, and 13.3% males presenting with HIV. Next. So this was the response of the patients according to if the patient was afraid of taking the medication or not. So as you can see, most females at 43% said they were not afraid of taking medication, and 16.7% said yes, they were afraid. And males at 33.3% said they were not afraid of taking medication, and 6.7% saying they were afraid of taking medication. Next. So these were the causes of the failures to take medication. It was according to either the color of the drug, if the patients needed a different drug, or the quantity of the drugs, if maybe it was increased or reduced, the size of the drug, or if they were just generally afraid of the side effects. So the females, 25% say they failed to take their medication due to color, 25%. 12.5% they said they didn't take their medication due to increase in quantity. 12.5% of also the females say they didn't take the drug due to size. 4.17% of the females said they didn't take their meds because they were afraid, and 12.5% said they didn't take their medicines because of the side effects. Males, 12.5% say they didn't take due to color. 4.17% they didn't take their drugs due to the quantity. 8.3% didn't take because they were afraid, and 4.17% due to side effects. Next. So this the patients were asked if the number of drugs that they were being prescribed were increased. We had females saying yes, the drugs were increased. The females that said yes, the drugs were increased were 39.13% of the study population, and 21.7% said yes, no, the drugs were not increased. Males, we had 21.7% said the drugs that were being prescribed were increased, and 17.37% said the drugs that they were being prescribed were not increased. Next. So also we asked them if the number of the drugs that they were being prescribed were reduced. We had females at 35.7% of the females saying that the drugs that they were being prescribed were reduced, and 28.57% saying that the drugs that they are being prescribed are not reduced. And the males, we had 28.57 saying the drugs are not reduced, and 7.14 saying they are reduced. Next. So we asked also the participants if they skipped at any time, did they skip their medications. We had females at around 50% saying yes, they skipped. Majority of females saying they skipped the medication at around 51%. And females at around 11% saying they did not skip the medication. So as you can see in the graph, most female participants skipped their medication compared to males. You see males are having only 22%, saying that they have skipped their medication for whatever reasons. Next. So these were the reasons for skipping the medications. We analyzed it according to the side effects, or maybe the patient got well, or they were busy, or the financial issues, or other reasons. So for females, at 14.9% said they skipped their medication due to finance. 17.14 saying they were busy. 2.86 of the females saying they got well, and also 2.8% saying they skipped due to side effects. Most of the red, as you can see, the female, the long red bar representing the other reasons, which were most of the participants stated that they skipped due to stigmatization. These were mostly the patients on heart, highly active antiretroviral therapy. Males, we have 0 of them saying they skipped due to side effects. 2.86 saying they skipped because they got well. 8.57 saying they were busy. 8.57 saying they skipped due to financial issues, and 14.28 they skipped due to other reasons. Next. So from the results that we obtained from the study, patients do not fear taking their medication. Most patients are described that the need to take medication as directly related to the state of their health. A patient was quoted saying, "I must take my medication because of my condition. If I fail to take, the condition may worsen." Most of the patients on hearts with more than one dose felt that they need to make the regimen a single dose for compliance. They also stated that there's confusion when the color of the drug was changed, because when they came to the CCC pharmacy, they found maybe the drug that they were taking before, it was a different color. So they were asking, is this the same medicine that I was taking the previous time? So they found the confusion in color changes of the medication. There's also stigmatization among HIV patients that led to most of them failing to take their medications because maybe they were afraid of being stigmatized. some of the patients maybe came to the CCC clinic and requested that they don't have the package of their medications displayed. Patients on antihypertensives and drugs for diabetes and heart failure stated the reasons for skipping their medications as the availability of the drugs prescribed for at the pharmacy. So most of the patients that were being covered by National Health Insurance Fund could not afford buying the medication outside the hospital, hence waited for the drugs until when they were next available. So when they missed the drug at the pharmacy, they were not able to purchase the same. They had to wait and to come every other day and ask if the medication is back, so that they missed some of their chronic medications. Next. Limitations of this study is that the findings are explored. The findings explored medication experience from multiple chronic conditions, and hence medication experience from specific illness could not be established. Also, even though the meta-analysis addressed the issue of small sample size in qualitative research, the study was had a relative small sample size of 30 patients, which limited the applicability of these findings to other experiences. Next. So in conclusion, medication experience is a practice concept that serves to understand the patient's experiences and to understand individual patient medication experience in order to meet his or her own medication-related needs. Understanding the experience of patient presented in this paper can serve to guide healthcare practitioners who are interested in meeting patient medication-related needs, and to provide a foundation for meeting and interpret each individual's patient experience. Additional research is needed to further understand medication experience and examine it to optimize the patient's medication taking behaviors. Next. So there's need for pharmacists to get involved in MTM, which includes medication review, patient medication record keeping, medication-related action plan, interpretation and referral, and documentation also follow-up. Pharmacists should be engaged with other medical practitioners to enable patients get the right prescription for the right indications in the right route of administration. So I would like to acknowledge the chief pharmacist, Coast Provincial General Hospital, Dr. Jones Makori, who was my mentor during my program on internship, and Dr. Jacob Suleiman, who was the clinical pharmacist, Coast Provincial Hospital, who was also my mentor during my period of internship. Thank you.
Thank you very much, Dr. Brian Wafula, for giving us a very informative presentation. And this really makes us appreciate non-adherence issues amongst our clients. And we all know that adherence directly affects the treatment outcomes that our clients experience. And it really speaks close to home because we all have experienced this sort of issues of non-adherence without really understanding why the patients don't take their medications. So it's interesting to note that something like color, the size of the tablet, the side effects of the drug can actually make a patient decide that they're going to skip their pill for the day. So thank you so much for that very eye-opening presentation. And I'd like to remind us once again, if you have any questions that you would like to direct to the presenter, kindly post them in the Q&A tab and they'll be answered there. So we are going to move to our next abstract presentation for the day, and that will be by Dr. James Mailu, and he'll take us through his abstract on medicinal plants used in managing diseases of the respiratory system amongst the Luo community, and this is an appraisal of Kisumu East Sub-County in Kenya. Welcome, Dr.
Okay, thank you very much. Sorry, I have a slight cold. Kindly bear with me. So next slide. So infectious diseases, including respiratory infections, are a major cause of death globally, and that can be found in literature, studies done by individuals, including the World Health Organization. And despite maybe a lot of effort made towards combating infectious diseases, they still are a major cause of morbidity. And the global burden of disease 2017 ranked lower respiratory tract infections as the fourth leading cause of early death. And in Kenya, the KNBS, Kenya National Bureau of Statistics Economic Survey of 2020 listed respiratory diseases as a leading cause of morbidity in Kenya. And these are some of the aspects that informed the study. Next slide. So pneumonia, based on the KNBS Economic Survey, pneumonia was listed or considered as the leading cause of children under 5 admissions, and up to a tune of around 21,383 cases were recorded for the period 2017 to 2019. And diseases of the respiratory system hurt individual productivity, reduces ability of people going to work, ability to do their normal daily activities, and they are responsible for more than 10% of all disability adjusted life years. So the injury that results from respiratory infections is very apparent, and therefore various efforts should be made towards mitigating this particular condition. And in developing countries, various studies have shown that there's poor access to healthcare, and this poor access to healthcare has led people to seek herbal or herbalists. And some literature indicates up to 80% of residents in rural areas tend to seek herbalist interventions. And from the study, we found that most people actually sought interventions of the herbalist before they went to a clinic. Yeah. And unfortunately, most of this knowledge on herbal medicine is often undocumented. And we find the custodians of this knowledge are always the elderly. And the elderly, most of it is because of cultural aspects, whereby various cultural practices or beliefs limit the time in which you can engage in such practices. And this information can try to facilitate scientific inquiry into new therapeutic molecules. So materials and methods. The study was conducted between March and September 2019, and semi-structured questionnaires together with interviews were used to collect this data. Out of snowballing, we were able to interact with 30 local herbalists who were considered to be knowledgeable on medicinal plants used to manage respiratory infections. Because of the age and education levels, the interviews were conducted in Swahili and in Luo, and a taxonomist familiar with the local flora and dialect was recruited for the study to aid in the interview process. Next slide. So the interviews sought to answer the following questions. 1, what plant species are used in preparation of the remedies? 2, which were the plant parts commonly used? 3, methods used to prepare the remedies? 4, what were the common respiratory illnesses treated in the area? 5, how are the indigenous remedies administered? Next slide, please. So that was a summary of the demographic characteristics of the herbalist interviewed, and the majority of them were females, constituting around 86.7%. Majority of them belong to the older age group, that is 61 to 70 years of age, constituting a total of 43.3% of the total interviewed herbalists. A majority of them had no formal education, constituting to 56.7%, and only one had a secondary level of education. The years of experience was very key in such a study. You always want to target people who have been in the business for quite some time so that you're able to get an expert opinion. And we found that majority were between 11 years to 30 years of practice, constituting to 8, 9 respectively, which constitutes 26.7% to 30% of the total interviewed participants. Next slide, please. So that is just a pictorial. You can see we are trying to collect, that is in Kajulu Hills. That was during the collection of the plant species. Next slide, please. So that is just one of the plant species. We were able to collect a total of 45 plant specimens that were deposited in the herbarium. That is one of the plants. It's called Euclea divinorum. The local name is Ochol. Next slide, please. Next slide, please. That was also another plant referred to as Ofunjamuri in Luo dialect. And the botanical name is Croton megalocarpus. And for the two plants, the roots were utilized and the leaves for purposes of preparation of herbal remedies. Next slide, please. So out of the study, we were able to identify 45 plant species that were distributed among 43 genera and 28 families. The two dominant families were Rutaceae and Leguminosae, which were dominant with 5 species each. The families Lamiaceae and Asteraceae had 3 species each. In terms of habit, the highest number of plant species were trees, which constituted 44.4%, shrubs 37.8%, herbs 8.9%, climbers 6.7%, and cones, which was 2.2%. Majority of the plants were sourced widely from the world, so they were not grown within the homestead of the herbalist. So the herbalist just used to wander within the forest or within Kajulu Hills and source for these medicinal plants. The 3 plants, Euclea divinorum, Tylosema phasoglense, and Carissa idionica, were the most cited plants with relative frequency of 0.67 and 0.67. So in terms of agreement among the herbalists, most of them felt that these 3 plants were the most cited with regards to management of respiratory infections in that particular area. Next slide, please. So plant parts that were used, in terms of percentage, majority were leaves, which constituted 33%, roots 28%, and the stem bark, which was 24%. Method of preparation, the most common method of preparation was decoction, and this just refers to boiling the specific plant part in water, then you administer concoction, which is a combination of either 2 plant parts, either a leaf or a bark, and boiled together and administered, and chewing, which was 44.2%. Other methods of preparation included cold maceration, powdering, and also instillation or infusion within the nostril. So if it was something that had a sap, the patient will have been advised to press that particular plant and instill maybe the sap either to the nostrils. The main route of administration was oral. Next slide, please. So the pharmacological and toxicological reports, the literature survey done, and that was used various platforms, including Google Scholar, PubMed, Medline, PubMed Central, and we're able to get previous reported activities, either traditional uses and pharmacological uses of the named plant species in the study. And a total of 95.5% of the plant species had reported pharmacological or chemical activity. It was noted that for two plants, Croton dichogamus, which was referred to as rachar in local Luo dialect, and Raichosia elegans, referred to as jandarusi. Oh, sorry. I hope it's better now. Sorry about that. Sorry about that. Thank you.
It's okay. You can proceed.
Okay. So the two plant parts, sorry, Croton dichogamus and Raichosia elegans had no reported pharmacological activity, and that maybe gives a small room for further studies and find or validate their use. I'm trying to use my Wi-Fi.
Dr. Mailu, are you with us? We seem to have lost you, Dr. Mailu. Let's give him a few seconds to connect back.
Sorry about that. Is it now?
You still sound a bit unclear.
I think it's my network connection.
Yeah, it's probably related to network.
I've tried to use my Wi-Fi. I'm back on my phone tethering, I think. Is it better now?
Yeah, it's a bit better. Just maybe you could just move closer to the mic. That would help.
Yeah, I'm very close to the mic. Sorry, doctor, is it better?
It's
Still shaky.
It's still, yeah, a bit shaky.
Then maybe I can try to use another device.
That's better. That's better. That's perfect. You can proceed.
Better right now.
Yes.
I proceed.
Yes.
Sorry about that.
No worries.
79.5% of the plants were reported to be affected against microorganisms associated with the respiratory illnesses, and that shows there's some degree of agreement with regards to use of these plants in combating respiratory infections. And a total of 4.1% of the plant species had no toxicological data, and that includes Croton dichogamus, Raichosia elegans, Molligo medicalis, and Associates trivoli. Remember, whenever you're using herbal medicines, despite their effectiveness, you also have to do local analysis to see the suitability in their use So again, this also offers a small.
Sorry, Dr. Mailu.
Yes.
Unfortunately, we are experiencing the same problem. You seem to be disappearing. Yeah, we can't hear you quite well.
Oh, sorry.
There, that sounds better.
So will I be given another chance, or I try to log in using another device?
Sorry?
Will I be given another chance to present later on, or I try to log in using another device?
I can't hear you. Could you kindly try logging onto another device?
Yeah, that's what I'm proposing. Kindly.
Okay. Sorry about that, fellow participants, but as Dr. Mailu tries to sort his internet connectivity, I would like to request, if you have any questions for the presenters, kindly post them in the Q&A tab and they'll be answered accordingly. Thank you. And also just a reminder, don't forget to log on to the PPB portal so that you can be able to claim your CPD points for the day. A video will be played later on during the session showing you how you can go about that. Thank you.
Hello, is this better?
It sounds a bit better.
A bit better. I think it's network issues from my end.
Yeah, that's definitely better. You can proceed.
I'm very sorry about it.
It's okay.
Yeah, so next slide, please. So conclusions, we saw that there was dominant use of roots, root backs, and root tubers, and these threatens vertical survival of some of the plant species used. And various studies have shown that predominant use of these plant parts they promote uprooting procedures, and therefore survival or maintaining the ecological diversity is compromised. Another, we observe that it is very important to preserve the medicinal knowledge in the third area. Majority of the herbalists were old. So majority of the herbalists belong to the older age group, and the need for preservation of that information is very key. The younger ones were not very interested. Also, some cultural practices only limited inclusion of participants in the herbal practice once they got to a particular age. Then there are plans already underway to conserve some of the medicinal plants documented. Some of the herbalists had been trained and issued certificates on how to conserve, and only collected plant parts that were only suitable for their use at that particular period of time. And again, there is continuous need for scientifically to scrutinize these medicinal claims and validate their use. Next slide, please. So limitations of the study. One was the dosage frequency. It was noted that there was a lot of ambiguity and poor agreement with regards to various herbalists on how you dose particular plant parts or remedies. And the duration of treatment also was ambiguous. And majority of the dosing frequency and duration of treatment was actually borrowed from whoever the herbalist learned the trade from. If they observed their dad or their uncle, they also administered the plant parts in the same manner.
Okay, thank you. That is all for me.
Thank you once again, Dr. Mailu, for just reminding us that conversations around herbal medicines use cannot be ignored, and they're very important, especially when looking at primary healthcare in our settings. So thank you for a very informative presentation. And I'd now like to welcome our next abstract presenter, Dr. Audrey Mumbi, and she'll be taking us through examining the implementation of HIV prevention policies in private retail pharmacies in Kenya. Welcome, Dr. Mumbi.
Thank you very much. As she mentioned, my name is Audrey Mumbi. I'll be presenting a study conducted for my postgraduate diploma at the Kemri Wellcome Trust on examining the implementation of HIV prevention policies in private retail pharmacies in Kenya. Next slide, please. So just a brief background, HIV is still a global health challenge with over 37 million infections globally. There are highly effective interventions for HIV, such as the use of ARVs, use of condoms, pre-exposure prophylaxis, testing and counseling, voluntary male circumcision, among others. But the suboptimal implementation of these interventions has been a great barrier on their impact. According to the last survey conducted by the KenFair, the prevalence in Kenya is about 4.9%, which is about 1.3 million people living with HIV, but 20% of people living with HIV remain undiagnosed. For this presentation, I will focus on pre-exposure prophylaxis and HIV self-testing. Next slide, please. So HIV self-testing was launched officially by the Ministry of Health in May 2017, and it recommended delivery through private retail pharmacies. However, delivery through other channels has been well established and is ongoing, such as through public and private facilities, and also community-based delivery is ongoing. Next slide. Yeah, so the focus here will be on the pharmacy. Pre-exposure prophylaxis was also launched by the Ministry of Health in May 2017, and also recommended delivery through private retail pharmacies. PrEP is currently available in both public and private facilities, but there are no firm plans for the delivery through pharmacies. However, there's a study ongoing in Kisumu and Thika to try and establish how this can be done. So the reasons why pharmacies are being considered for the delivery of these two is because, one, they are highly accessible. They are many in number compared to public health facilities. They are conveniently located for majority of the people. They also offer speedy services, and they are open for long hours. This is debatable since private clinics open longer than pharmacies. Next, please. Pharmacies are also associated with client anonymity. And they also have capable personnel such as the pharmacist and the pharmaceutical technologist who can assist the clients. And they're also perceived to be somehow of low cost, though this is also debatable. Next slide, please. So when it comes to HIV, delivery through private pharmacies has been well established in the US, where clients go for ARV refills through private pharmacies. They also get adherence support through the pharmacies, and also supply of clean needles to people who inject drugs. Delivery of PrEP through pharmacies is also emerging in the US. Here in Africa, delivery of HIV-based services through pharmacies is emerging in Nigeria, where the clients get ARV refills for the stabilized patients. Next slide. So our main objective for this study was to assess the implementation of the HIV self-testing and PrEP in the pharmacy sector. Specifically, we were looking at the capacity available for their delivery, the level of adoption, and the service providers' motivation and challenges in providing the HIV self-testing and the PrEP. Next slide, please. So this study took place in Nairobi, Mombasa, and Kisumu counties, and we selected these three counties to represent the three different regions of Kenya, that is the Western, Central and Coast region. Another reason why we selected these counties is because the 3 counties have a high HIV burden. They contributed to 25% of the new infections in 2018. Another reason was these 3 counties host majority of the pharmacies. They host 32% of the licensed pharmacies and 77%